Good morning, and at the outset, thank you Dr. Ramurthy and AIOS for this opportunity. It's my proud privilege to be here. There are no financial disclosures. So I'm going to talk about a question that has been asked by residents, by patients, by referrals, that RNFL thinning is the only abnormal finding, so should you lower the intraocular pressure in these patients? So we do know that nerve fiber layer defects precedes visual field loss. These papers have come out more than 2 decades ago. And the reason is redundancy, because each test point of the visual field is subserved by many retinal ganglion cells. But having said that, it's important to remember structure does not always precede function change, and that's come to us from the ocular hypertension treatment study. 55% of patients progressed by disc alone, 35% progressed by visual fields alone, and 10% changed in both simultaneously. But it's important to remember that the oaths did not examine the retinal nerve fiber layer. So what does a thin RNFL or a red flag mean? It's important to understand that green only means within normal limits, which is within 95% of patients in the normative database of the OCT machine, which is around 300 odd patients. A yellow means that RNFL thickness is within 1 to 5% of the normal database, and a red only means that it's present in less than 1% of normal people. So that means an RNFL thickness which is flagged in red is present in about 1% of normal individuals, because it's in reference to a normative database. So when can it be red? Of course in glaucoma, but then also in non-glaucomatous damage, and don't forget bad scans. So this classic picture of glaucoma, POAG, one eye, pressures of 24, inferior nerve fiber layer defect, corresponding visual fields, and yes, of course, an RNFL flagged in red warrants lowering pressure, but then retinal nerve fiber layer is not the only abnormal finding, is it? This patient has normal IOPs, but he is 25 years old. He's been on steroids for 3 years. He has a posterior subcapsular cataract, because of which the discs are not seen too well, and he has bad fields. So we take out the cataracts. After undergoing phaco, we can see his discs better. Pretty advanced glaucomatous optic neuropathy, advanced field defects, and of course red RNFLs. But the damage is occurred. The IOP is controlled, and the steroid-induced glaucoma is over. So let's just watch it. So on the follow-up, the pressures have remained 12 and stable without treatment over the last 4 years, and we don't really need to treat him as yet, even though the RNFL was red. Now someone comes to me that my mother has these disc pictures, and these are the retinal nerve fiber layers, and somebody has said her pressures need to be low. So do you go ahead and advise a prostaglandin, or do you say call back your mom? And when the mom comes, there's trauma, there's head injury, there's RAPD, but the pressures are normal. So yes, the retinal nerve fiber layer is flagged in red, but her pressures don't need to go down. So if you have a disc cupping with temporal pallor and the vision is down, the fields show scattered defects, and your RNFL is red. But look where it's red. It's red at the temporal side, whereas in glaucoma it's the papillomacular bundle which is preserved. So then you go further and you see that since the temporal fibers are down, let me do a VEP, and it turns out she has a Leber's hereditary optic neuropathy. Why would you want to lower her pressures? But beware, this ocular hypertension with 24 and 26 pressures, thicker corneas, normal discs, normal swab, not just fields but normal swabs. But yes, the retinal nerve fiber layer is red. So now what do? Do you lower his 25 pressures? But if you look carefully, the scan is beheaded. So if you're not going to take the entire retinal nerve fiber layer in your scan, the scan is going to show up as flagged as less than 1% of normal. So look at your OCTs, repeat them, and sure enough, this is what you expect to find. And these are his GPAs over 5 years. They're absolutely stable and in a straight line. So this guy doesn't need his 24 pressures to be lowered either. But what if there is change in retinal nerve fiber layer thickness now? That's another story. So sometimes, and I just take you through this patient of ours in the last 10 years, and it's a real quandary. He's unilateral POAG, the person I showed you. In 2004, he comes to us pretty much straightforward, primary open-angle glaucoma, and we put him on treatment. He's stable over 3 years. Till 2006, his fields start going down, and the mean deviation slope is significant. And you start wondering what's wrong, because then the GPA shows up a possible progression, but his pressures are still 14, and there's nothing to suggest that there is anything going wrong. So you tell yourself that he's stable on follow-up on the discs, he's stable on the OCT, which are absolutely straight lines. Probably he's had a bad day. You don't panic. You do the fields again. Sure enough, the possible progression disappears. The mean deviation from significant becomes non-significant. The points that have gone down here come up here again, and you pat yourself on the back and say, see, I told you you were alright, you just had a bad field day. So till 2011, it's all hunky-dory. Now he's got 7 years on the OCT, and it's absolutely straight and fine, and you're feeling very pleased with yourself. And then you acquire a cirrus, a spectral domain. And the cirrus tells you, something which was yellow becomes red, and something which was red becomes thinner. And now what do you do? So the cirrus gives you a GPA. So you do a progression analysis. The right eye is normal. This is what the progression analysis is. No ticks here, but look at this. Possible progression in 3 different areas. So now what do? You look at his discs carefully again. 2004, 6, 9, 12, 13, and you don't see anything going on there, either in the right or in the left eye. The visual fields on the GPA till September 2013 shows no progression. It's absolutely normal, but statistically there's no progression. So now what do? You have an RNFL change, you have pressures of 14, your fields are stable, but your OCT says there's progression. So then, do we treat it further, or do we just do it once more and wait a little more and not panic? So we repeat it. And once we repeat it, the fields show progression, possibly. So on 3 consecutive fields, finally you do have progression. Now this is a patient where I'm really, really worried. And this is a patient where the cirrus GPA between September 2009 and Jan 2014 shows up a significant progression in one eye. So here we need to act. Even if we've shown it before and the fields did not progress, it shows up, it's a demonstration of how structure does precede functional loss, and this RNFL thinning, because it's a change, warrants treatment and for lowering IOP further. So to summarize, it's rarely appropriate to begin initial treatment based solely on RNFL thickness alone. You need to look at, is the RNFL thinning real? You need to gather and assess all relevant data. A large variability means cross-sectional data is not good enough. You need to show change, and you need to look at life expectancy and risk tolerance for treatment. Thank you.